Luis Fernandes, and I'm one of DTN fellows based at the Center for Health Economics in the University of York. The study that I'm presenting here is a joint work with both my supervisors, Niels Gutak and Martin Cholkley, and we look at the impact of the clinical environment on surgeons' treatment choices. So our paper focuses on drivers of variation in treatment decisions. There is a large literature showing that variations exist across different regions, providers, and patient populations, and they persist across time despite several policy attempts trying to reduce them. And so if we want to tackle such variations, we first need to identify their drivers. And conceptually, drivers can be separated in two main components: a patient demand side component and a provider supply side one. For some time, we thought that variations were mainly due to differences in patient demand side factors, such as patient characteristics and preferences. Yet several studies have shown that these factors can only resolve variation to a very limited extent. Less, however, is known about the supply side factor component. Only recently, in a paper by Amy Finkelstein and authors in 2016, we were able to separate the demand side from the supply side component. And so the authors find that more than half of the geographic variation in US healthcare utilization is attributed to supply factors. So there is a very large effect. Yet the authors are unable to advance or suggest any specific factors within this component. And this is where our paper comes. So we first hypothesize a supply-side explanation for variations. And there are two main hypotheses here. One, hospitals might have causal effects on treatment decisions made by physicians, which means that if we were to move a physician from one hospital to another, we would expect his treatment start to converge to the treatment pattern in the new environment. A second hypothesis is that there are systematic differences in the type of physicians practicing in each hospital, which means that perhaps physicians who have like beliefs and preferences relative to treatments, they might flock in the same area and give rise to hospitals that have distinct treatment patterns. And so in this paper, we explore the relative importance of these two hypotheses and examine whether surgeons' hospital environment impacts their treatment decisions between cemented and cementless hip replacements. When we look in the literature, the two closest papers to ours are from the US. One by David Cutler in 2019, where the author finds that organizational factors matter, but the most important factor is physician beliefs about treatment, which are able to explain 35% of the spending in end-of-life care and 12% of the spending in heart attack treatment. The other paper is by David Molitor in 2018, and the author looks at treatment choices made for heart attack by cardiologists in the US. And he finds that environmental factors explain between 60 and 80% of the differences in physician behavior. So the contributions of our paper are related to the second that we explore. We look at hip replacement surgery, which is the most common surgical procedure worldwide, and for which there are two main substitutable implants, cemented and cementless prostheses. And so both of these are widely available in hospitals in the UK. Surgeons are trained in both methods. They have similar therapeutic success, and there are no clear clinical guidelines. The other advantage of our setting is that there is a lack of financial incentives. And this is because, one, procedures are equally reimbursed to hospitals in the UK, and two, surgeon pay is independent of the treatment choice, since in the UK, we have a salary-based system for hospital specialists. And so in terms of policy implications, our question is relevant because if we want to tackle variations, we need to understand if we should design policies that target surgeons or hospitals. In terms of data, we use data from the hospital episode statistics. This is patient-level administrative data from all publicly funded care delivered in England. It is a very rich database, which includes patient characteristics, clinical information, and details on the admission pathway. And most important for us, it includes surgeon and hospital identifiers. And therefore, we are able to identify the surgeon that is responsible for the care. And so we go in the database and first extract patient episodes of primary total hip replacements between 2010 and 2017. And this includes a universe of more than 300,000 patients who are treated by more than 2,100 surgeons. And then we use this primary sample to define a subsample. In this subsample, we use surgeon identifiers, and we follow surgeons along across the sample period to construct employment histories and then identify surgeons who move their practice between two hospitals, which we define as the hospital of origin and the hospital of destination. So following this strategy, we were able to identify 74 surgeons. They treat more than 8,300 patients. So to understand our empirical strategy, we first need to clarify how we measure clinical environment and how we construct our treatment variable. So we define clinical environment to be a hospital cemented rate, which is the proportion of cemented cases to the total of hip replacements that are performed in a given year in a certain hospital. And when we compute this rate, we exclude the moving surgeon cases so that we avoid kinemetric issues in our estimation. Then we define our treatment variable to be the change in a risk-adjusted cemented rate between the hospital of destination and the hospital of origin in the year of the move, which we define to be the delta J. So our empirical specification is laid down formally below. But what it means is that we traced out how moving surgeons' treatment choice changes as a function of a change in environment that they experience across the move. So the coefficient of interest in our specification is the beta highlighted in blue. So in terms of results, I have 3 models here. In the first model, we only include surgeon fixed effects. Then we add year dummies, and in the final world patient characteristics. We're going to focus on the third model in the third column. And the coefficient beta is highlighted in bold. And the interpretation is that a 10 percentage point change in the environment leads to a 6.4 percentage point change in a surgeon's propensity to adopt a cemented prosthesis. And what this means is that for a surgeon who is moving to a higher cemented environment, we expect him to increase his adoption of cemented cases. And this happens vice versa for those moving to low cemented environments. In the subsequent analysis, what we want to do is to understand how a surgeon practice style changes over time relative to the change in environment they experience across the move. And to do this, in this plot, we have in the x-axis quarters of the year relative to the move. And then we have plotted the coefficients for this estimation. There are 2 main observations here. First, to the coefficients to the left of the vertical dashed line, which are before the move, we see that they are close to 0 and roughly flat. And this shows that a surgeon practice style before the move doesn't change systematically with a change in the environment that they experience across the move. And therefore, there isn't much evidence of a selection in the hospital where they migrate, where they move. And the second observation is for coefficients to the right of the vertical dashed line, which are for after the move. And we see a jump happening at the time of the move. And then the coefficients remain flat for the remaining time. And this means that there is no scope for learning in the new environment or for a phase of adaptation. They just quickly move. So briefly to conclude, we saw that the clinical environment has a significant effect on the choice of the method of fixation. We find that the 10 percentage point change in the hospital environment leads to an average change of 6.4 percentage point in a surgeon's propensity to do a cemented procedure. In this last analysis that I've shown, we observed that a change in surgeon's practice style occurs right after the move with little to no further adaptation to the new environment. And so what our results show in terms of policy implications is that policies aiming at changing the clinical environment can have a large effect in the short run, whereas those targeting surgeon-specific factors may only have an effect in the long run. Thank you very much.